our next session is around opioids, and we got started on that this morning. And as former secretary, I can tell you this is about as vexing a problem as we've run into. And I agree that we don't understand it as well as we should. We don't have the systems in place to deal with it, but my takeaway is it's really not just about opioids that we have to think, because the drugs will change, and we will continue to have addiction, and we will continue to have behavioral health issues, and we will continue to look for that alignment between health and healthcare and the social determinants that impact both. So if we can be really, really smart and figure out how to use the tools to solve the problems that my board, your boards are interested in, the 140 legislators, the governor, the CEO, if we can get programs in place that are sustainable, that will work beyond this, I think we've really hit a home run. So this is a tremendous interest to me. Our panel this afternoon is about breaking down silos, and all of you know that in Virginia, in Richmond anyway, we call them our cylinders of excellence, right? We do. It's important to realize that that's a Richmond thing. But I'm not in Richmond anymore, so I can talk about silos. We have a couple of examples here, 3 today, of what's being done and how we can build on state and local activities. And so first we'll have Karen Smith, who's the director of California Department of Public Health. We have Judge Anthony Capizzi, I think, who is a juvenile court judge from Montgomery County, Ohio, which is really ground zero in some ways in dealing with the crisis here. And then we have, I guess, are you major or are you colonel now, retired? I mean, I think Daniel gave you a promotion. Okay, Juan Colon from New Jersey. And it's really important to listen to what the judge and what Major Colon had to say, because those of us who work in the health and human resources sector need to figure out how what we do is so important to the courts and to the law enforcement community, and how what they do is so important to us and how we reach across those domains. Now, my instructions are between speakers to ask the speaker who's just finished what would be the key learnings from their work that could be applied to other domains. Also to say, is there a useful best practice that we could share that might impact other domains? And then what problems did you have and how did you get around them? So I'm just warning you about this. So you'll be prepared for those questions right on time. All right, Karen, you're up.
Okay, thank you so much for the opportunity to talk to you. I'm going to talk a little bit, let's see, here we go. You know, we've been talking about interoperability as if it was exclusively a data thing. And I think the point I'm going to make, I'll give away the main point of my entire conversation, which is that you actually have to have programmatic interoperability before you can get to data interoperability. And I think the Silicon Valley Trust is a really good example of that. It didn't start with the data systems. It started with the conversations about the shared goals, et cetera. And that has a lot of echoes in what we've been doing in California in terms of addressing the opioid epidemic. So for me, as a long-term public health person, the opioid epidemic is kind of the perfect public health issue, and it is a public health issue because our approach to the issue is totally relevant. We have a focus on prevention and getting upstream of an issue, meaning what are the causative factors, and if we don't do that in the opioid epidemic, we are not going to handle it, period. There's just no other way. We can try to mitigate the downstream effects, but if we don't move upstream, ultimately we're going to continue to have the downstream effects. Also, the issue of conducting surveillance and understanding, tracking what's going on and what are the factors that are precipitating it is at the core of what public health does. And that's essential to deciding what your interventions on any problem or any epidemic, including opioids, are going to be. The other key thing that we do is we provide education and guidance to all kinds of sectors of the society, from healthcare providers, in this case in opioids, to the general community. And that requires that you really understand what the levers are with those different communities in terms of what is useful information, what's actionable information. And then there's the perpetual seeking of resources to address the issue. And in particular in opioids, it's treatment and services, which has a lot in common with almost almost every other epidemic. But in addition to being kind of a perfect public health problem, it's also a textbook case for interoperability strategies. This is fundamentally a multi-sectoral problem. We've spent a lot of time in the last couple of years looking at, what do we do about doctors who are prescribing too much, too little, inappropriately, whatever politically correct way you want to talk about it. But if that's all we do, we have a lesson learned from Indiana about what happens when you do that. If you don't handle the other issues that are driving this epidemic, it's not just the doctors. If you take away all the drugs, you can take away all the opioids, and what you get are people going into the illicit drug system and all the problems that come with that, including sharing of needles and HIV and hepatitis C, and even bigger problems than you had to start with. But also there are real opportunities to leverage data and pursue policy as an incredibly potent intervention in this particular epidemic. And policy across the various sectors, not just health policy, but also law enforcement policy, mental health kinds of policy. There's policy in every aspect of the sectors that will actually help us. I'm going to overview for you California's strategy to reducing opioid deaths and overdoses, which has a foundation in multi-sector collaboration, and a couple of examples of how we're using data interoperably in California. Just so you know, these are all screenshots, not the text, from our opioid surveillance dashboard, which I'll talk a little bit more about. So in California, our rates, both for all of the indicators of the opioid epidemic, are actually lower than the national average. But because of our size, the problem is huge. We have over 2,000 deaths every year. We have about 8,000 hospital and emergency department visits, and over 24 million opioid prescriptions written every year. We do have an issue with fentanyl, not to the degree that areas further east in the United States have, but the problem is increasing. We have some good, and the other thing, the issue, some of those states particularly the states in dark, or counties rather, in dark colors, are rural counties. There are some counties that have rates of opioid overdoses and deaths that are as high as the highest states in the rest of the country. It's a very geographically diverse epidemic in California. We do have some good news. We have seen declines in the number of prescriptions written over the last couple of years, as well as the morphine mill equivalents in those prescriptions. Since 2010, we've seen some significant decreases, and that we consider that a win. The overdose-associated deaths peaked in 2009, and we've had a 10% decrease since 2016, and I'm going to talk a little bit about why we think that's happening. The flip side of that is heroin overdose deaths have sharply increased, about 64% since 2012, and there has been a 180% increase for heroin-related emergency department visits. So we are seeing the same phenomenon that has been seen elsewhere, which is as we tighten down on the problem that's the actual prescribing, the availability of prescription opioids, people are transitioning into the illicit sector with all the problems that come with that. The pattern remains that the issue's most severe in the rural parts of California. Okay. So first I'll talk a little bit about some of the activities that we have that I think are contributing to the trends, particularly in prescription overdose issues. We have a very active and dynamic statewide working group that is called the Statewide Opioid Safety Working Group. It started as data sharing, information sharing, I should say, since there wasn't any actual data going back and forth, but there was people coming together to talk about issues that was within the administration. So they were state-level agencies, Department of Justice, which is where the prescription drug management system resides in California, Public Health, Department of Healthcare Services, and others coming together to talk about the issue, starting to speak with one voice about opioid epidemics. Since 2015, we've expanded dramatically. The first external partner actually to ask to join the group was the DEA. And they've been a very, very useful partner to us. But at this point, we have 22 work group members. These are all agencies or organizations, and we do have, including at the local level and then within the nonprofit sector, there are over 40 entities that are actively participating in our task forces. We have 5 task forces associated with the work group, and they are the Integrated Healthcare and Policy, Task Force Treatment, Communication and Outreach, Data Gathering and Sharing, a very important one for this group, and Maternal and Perinatal Issues. And so we have people working on each of those. Essentially, what we are doing in California is we are leveraging this collaborative but very strategically focused group of agencies to build a comprehensive shared agenda with shared measures and mutually aligned activities. In fact, not just aligned, but mutually reinforcing, very intentionally mutually reinforcing activities so that we can each stay in the lane that we're paid to be in and yet really work actively with one another to enhance the outcome of those. You'll know this as a collective impact approach, although we're not supposed to use that term because it's actually been, what's the term when nobody else gets trademarked? Thank you. By Stanford, where I used to be. Figures. At any rate, who knew you would trademark something like that? We're going to use it anyway. So we have seven essential strategies that fall into these 4 areas, and every one of the participating organizations works on these to one degree or another. Safe prescribing, obviously, building community capacity at the local level. We have 25 intersectoral, cross-sectoral collaboratives. They're either regional or county-based throughout the state of California that we support. They're doing the same work at the local level, but specific to their community that we're doing at the state level. And that has been one of the most effective approaches to the epidemic. Actually supporting those coalitions they actually share data more easily within their jurisdiction than we're able to do at the state level. So we're actually learning from them in terms, and that's particularly true when it comes to education data, but also law enforcement data. It's very hard at the state level to share law enforcement data, at least in California. We're also expanding medication-assisted treatment and then distributing naloxone to prevent overdose deaths. A lot of public education also going on. Every single one of these strategies is dependent on data to be actionable. And so there is a lot of focus on using data and trying to be more interoperative. This is just an example that if you could read those, you'd see that they're very specific strategies. What we're trying to do is build a framework where we can leverage that collective action across a variety of sectors, ever expanding that array in mutually reinforcing activities that span policy, data, education, community engagement, and with opportunities for any organization or individual who wants to participate, whether it's at their community or at the state level, to do so in a way that can help with the problem. And really, it's based on the idea, which I mentioned earlier, no single policy or government department or organization or program can tackle this particular issue. And so venues like our work group and the coordination, support, and convenings and catalyzing action through what we're calling a collaboration infrastructure. And this is actually furthering our ability with data interoperability, because one thing we did was we built trust. Again, there's that term. So essentially, if you build that collaboration infrastructure, and that's what I mean when I say programmatic interoperability, human beings who are running programs who talk to each other about how they can interact, that allows then cross-sector sharing and tools to be developed and empowers, especially at the local level, communities with information that they can use as actually actionable for them to decide what are the most important strategies for them. Nobody has enough resources to do all the things that we need to do. So we each have to take our little pieces and try to have them work together. And 2 examples of actual data interoperability in California that I want to mention. One is the California Department of Public Health has a partnership with the Department of Justice for a pilot effort integrating our prescription drug monitoring program, their prescription drug monitoring program data with electronic health records at the local level. So that right now, if a physician is actually soon will be required to enter information into the PDMP, they have to actually log on separately and do that. That's a hassle, you can imagine. And it actually creates a disincentive to participation. So we're actually all working together along with the Department of Health Care Services to have it so that it's fully interoperable with their electronic health record, so that when they pull that patient up, they can automatically see a flag if that's a patient that has been flagged in the PDMP, or if they're entering, they can also see without having to leave their system all the other physicians that or other prescribers that may have given this individual. So all the rich data that's available in a PDMP is available to the physician then and there without having to take any additional steps. And so we're just beginning to build that pilot out, but I think it has tremendous potential. The other I want to talk a little bit about, and I'll walk you through a couple of examples, is our opioid surveillance dashboard. There's actually an easier website now. This is the publicly available infrastructure that we've written this in, is this shiny apps. It is the California Department of Public Health website, so cdph.ca.gov. Just look for opioid surveillance dashboard and it'll bring it up for you. I'm going to show you some screenshots and talk about a little bit about what we're doing. This is leveraging multi-sector data to give you very geographically specific information that can be used to inform interventions at the local level as well as at the state level. The dashboards are also allowing us at the state level to do surveillance on short and long-term goals that we have within the statewide opioid safety path. So we're actually using this to evaluate our effectiveness as we move forward. Because this is intended to be used by the general public as well as by our local partners, it is an extremely easy to use system. You can very easily change the metrics that you're looking at, and the display is easily modified. It has little video tutorials buried within the program that are very easy. If I can do it without having to have somebody sit next to me and teach me for 20 minutes, almost anybody could do it. And it really is incredibly useful. Even an orthopedic surgeon, believe it or not, even a legislator. I've actually gone into some legislators. Sorry, nothing personal about legislators, but that's the other group that I was in Washington a couple of weeks ago, and a couple of the staffers said, oh yeah, I've used that several times, because they want to know what's happening in their district, which is, I think, really interesting. We continue to add functionality beyond the basics. So it measures overdoses, deaths, emergency department visits, prescriptions prescribed, number of milligram equivalents, et cetera, all data that's coming from the Department of Health Care Services, the Department of Justice, the Office of Statewide Health Planning and Development, which is where all of the discharge data from hospitals and other facilities comes from. So all that data goes into one place and comes in, as granular as the data that is available, that's how we put it up. So in some cases, the data is only available at county level. In other places, you can actually zoom down into zip code level. So if it's available at zip code level, you can get down to zip code level for any of those particular metrics, whichever one you're interested in. And this is an example. That's Alameda County, for those of you who don't know. Contra Costa County. Apologies to anyone here from Alameda. And you can see, when you look at zip codes, this can really help you if you're working at the local level. If you have limited resources and you want to put out some advertising or some sort of public messaging, you're going to do it in the areas where you have the greatest need. Or you're going to find partners who are working with that same population that's at risk in those areas. You get bigger bang for your buck when you can focus what you're doing. And just recently, we've added the ability to download in PDF format summaries of a particular area, whatever it happens to be, whether it's a county or a zip code, et cetera. And that has actually been incredibly helpful in terms of sharing information across to other people. So really, the broader opportunities here for us, and we're not quite there yet, but we're working on getting there, is leveraging the multi-sector collaboration to move further upstream, to look at those things that are actually driving this epidemic that are not physician prescribing, for example, destigmatizing addiction, changing the norms around how we think about people who have addiction, and increasing the access to medication-assisted treatment in every setting, including correctional facilities, for example. This is a new partner that we're bringing into our group, is the California Department of Rehabilitation and Corrections, to say, you have a population that's at very, very, very high risk. How do we work with you to make sure that they're safe when they leave the correctional facility? And what kind of data do you have that can help inform us and help inform communities that these folks are going back to? And in addition to that, are services available to vulnerable populations? How do we deal with youth who are coming into the system? What are the right sources of information, education, for example, but also who are the partners that are working with those populations? Pregnant women, tribal populations, et cetera. These are all if you're going to be successful working with any subpopulation, you have to understand the drivers of that population, but you also have to understand the resources that they bring to the table. And then finally, looking at the social determinants, the economic opportunities or lack thereof, that are underlying some of the sense of despair and the feeling of hopelessness that drives so many people into addiction, whether it's with opioids or alcohol. So these are some of the opportunities that I think we see with this kind of intersectoral collaboration, not just with data, but actually with the people who are doing the services. So that's it for me.
Question time.
Okay, question time.
Question time.
Did I do it?
I'm supposed to ask you about the key learning, but the key learning for me is I can't say collective impact. I didn't know that.
You can say it. You'll just get sued.
Okay, well, take a number. When you're secretary, that's what happens. Key learning from all of this.
Key learning for me is that it really doesn't take a lot to build trust if you can just come together, but trust just at the leadership level isn't good enough. You have to actually have people who are doing the work on the ground work together. So whether that's your data people, you have to bring the data people from across the departments or agencies together so they trust each other.
I always told people that we really don't do anything at the state. It's all done locally.
Yep,
Yeah.
basically.
So, what's the best practice, useful best practice?
I think the useful best practice is if you're going to bring people together, you have to actually commit to maintaining that relationship. You can't just come together once and then say, hey, we'll get back together again next year sometime.
And did you have any specific problems that you were able to meet and deal with that you could learn from or that you might want to share with others?
Yeah, it actually is possible for law enforcement and public health to work together.
It is.
And, so there are a lot of places where the drug monitoring programs are within public health, and there are a lot of people who think that that's the appropriate place for it. From my perspective, it actually, in California, it's exactly where it should be. And the folks in the Department of Justice aren't just interested in, finding people and arresting people the way we sometimes think about it from the human services side, but rather they really wanted to work together with us and have been actually our best partner in terms of finding, using the data to have other approaches, not just law enforcement.
So the aha moment was the law enforcement guys actually are good guys.
Well, I always knew
Wouldn't
they
go
were
that
good
far.
guys and they were willing to work together. That was the part.
It's interesting with this in Virginia. I think it really was a major turning point for us in our legislature when the police chief from Virginia Beach just stood up publicly and said what they're all saying, we can't arrest our way out of this. Exactly. We're tired of this too. We got to do something different.
Absolutely.
Thank you.
Thank you.
Judge Anthony Capizzi, Your Honor, do we have to stand all rise for the judge?
You're fine, Bill. Have a seat, sir. Hi, everybody. Come on. Hi, everybody. I know it's right after lunch, and we're going to do the best we can. I told the young woman earlier I'm not the geek. So not like most of you, I'm a policy guy. I say get it done, and I expect it to be done. And we hired the youngest 24 to 32-year-old people we could find to solve the problems that exist in the world. Okay. There is really no clicker here. I'm surprised. Oh, there it is. Okay. Let me just give you a background before I go into it. Oh, and first of all, if you want to look deeper into my presentation, there's a separate slide deck which is being put online, which is twice as long as this, to give you a fuller background, because I have 15 minutes to tell you 2 years worth of work.
When it goes online, the internet will crash. I've seen that deck.
Oh my God. Yeah. But who am I? I'm from a county. You heard Bill say that we're the epicenter of the drug problem, the heroin epidemic. My county per capita is the #1 death capital in the United States. We have 35 to 40 individuals every weekend ODing, not dying, but ODing every night. My population is about 540,000. To the legal age in Ohio is because I'm a juvenile court judge in Montgomery County, the other Montgomery County, which is in Ohio. I deal with a lot of cases. I have about 22,000 cases a year. I have both juvenile cases and adult cases, and my racial breakdown is 74 Caucasian, 20% youth of color. Who are we supposed to be? And I'm going to talk about technology and talk about interoperability, but the reality is I have a job to do. Every day you go on your computers and you're focusing on ways to break the bridges, break the silos. I'm talking about kids and families every day. And so my role is supposed to be a leader in effective and cost-efficient utilization of community resources. In other words, how can I get the best bang for my buck, least amount of money? How can I save people? Of course, provide for the protection of the community, and then bring sensitive and responsive individual victims and their families. I added a fourth one to that about 3 years ago. And my real job now is to keep kids from dying, to keep adults from dying who have little children. Because when the adults die, I have little kids in my court, and I don't have enough foster families to take care of those kids. So I used to think 14 years ago, going on the bench, those are my responsibilities. But the reality, in every juvenile court in this country, our crisis now is saving people's lives. And if you don't believe that, and I'm not a reader of Time magazine, but Time magazine in their March 5th copy, first time in 95 years history, Time magazine, they devoted their publication to one issue called the Opioid Diaries. The sad reality is half of this magazine's about my community. You can see the pictures from Montgomery County, Ohio, which are tragic about the people who I see dying every day. I was telling some people earlier today that I had 4 of my kids die since last year of fentanyl overdoses. So 5 years ago, I never had a child in my court. I run the largest drug court in Ohio, juvenile drug court in Ohio. 5 years ago, I never saw a child OD on opioids. And frankly, I think Bill said it earlier, it's not just an opioid epidemic, it's methamphetamines, it's everything else. And I would say this to you too. If you'd have asked judges 5 years ago what the next problem would be, we would have told you heroin and opioids. We know ahead of time because we see the ripple effect in our courts starting slow and blowing up. So that's the goal of what juvenile courts are supposed to be. Now, I actually have 3 courts that I'm using technology for now. I started the specialty court in 1998. I now have the largest one in the state, and my graduation rate is 64%, which is substantially higher than almost any other graduation of a treatment court. It is. And I'll say this to you.
It takes a judge to do that, a very special judge. So that is an applause line.
Thank you. And I have a family treatment court. What the heck is that for? My family treatment court started 2 years ago, almost 2 years ago, because I had too many young adults dying who have children. And so we opted to create a specialized family treatment court for those families that have young children and the parents are addicted to whatever the drug may be. Right now the hot drug is opioids, but we have a number of people on other drugs. Because the focus in that court is to say to you, if you stay in treatment, I'll let the child stay with you. Because 65% of children, once they're removed from and put in foster care, never go home. And that's not a long-term solution, putting kids in foster care. The third court I started just this past year is a life court. And that life court is a court, and you'll notice the names are not what they used to be. It used to be a juvenile drug court, a negative connotation. Now you have a treatment court. Same thing, family drug courts, a family treatment court. A life court is a mental health court for children. Because as I was doing my dockets in drug court, I realized a third of the kids in my drug court, their primary diagnosis is not drugs. It's mental health issues. And they were self-medicating. So those are my three different kinds of specialty courts. And I have crisis in every one of those. I have in the juvenile treatment court, I described you had some kids pass away this past year, 4 of them. In family treatment court, I have adults passing away either before or when they enter the program. I've had no one pass away yet in my life court, but of course it's only 8 months old. And so I'm hoping, and my kids in that court are substantially younger. I have kids 10 and 12-year-old in my life court who have such severe mental health issues, they self-medicate. I don't think we ever understood 20 years ago, we had a crack problem, we had other problems, what would happen to the babies? 20 years later, a person who was addicted to crack, what are they producing now? And I know that's a crude way to say it, but the reality is we're seeing a lot of children now who have substantially less brain capability and focusing capability because of the issues their parents and grandparents had 20 and 40 years ago. That's the reality of what I see every day. And that's why this crisis was so important to me, that we had to find a solution. And I found my solution 2.5 years ago coming here. I came to a Stewards of Change meeting 2.5 years ago and learned about the potential for maybe using Watson in a different way in the United States. And for the last 2 years, I partnered with Watson. I joke with them, IBM Watson Healthcare. I'm the intellectual property. They use me, they use my staff to create the most advanced specialty court solution to help solve the problem. And so what is Watson Care? And I don't work for IBM, I don't work for Watson. I just wanted a solution. I wanted a way to help me from having my kids dying and from the parents dying. I wanted a way that I can keep kids with their families while they're in treatment so I don't lose that possibility of them going home again. So Watson is basically a cloud-based management system. It works best, in my opinion, in specialty courts because in specialty courts it's a focus on health. And so this is a health-based program to begin with, used over time. Why? Well, you all talked and heard today about silos. Who are my silos? What are they? Well, there's BEH, behavioral health, of course. There's simply physicians, education, the police department, probation department. Every one of those is a silo, or as Bill said, this cylinder of excellence. But they don't want to work with each other. They didn't want to work with each other. And if they did, they told me after the fact. And so this is my treatment team. When I meet on all of my courts, I meet with someone from each silo. And they tell me what I hopefully need to know to help solve a problem and save a child or save a parent. And so through the use of technology, we've been using Watson Care to try and bring all of these different silos together. And I will say to you, I hear a lot this morning about the challenges of privacy, the challenges of who knows what about who. Maybe because I am the judge. I just ordered what I wanted. I said, I need all this information. Don't create barriers for me. One of my giveaways, I'll tell you now, is HIPAA's not a barrier. Doctors will tell you it's a barrier, but learn your way around it. All of these fancy little federal rules are not barriers. They're ways that you can work around them, and I don't mean illegally, of course. There are ways within those different requirements to get to know what you need to know, and I needed to know all of it. The reality is my treatment court's on Thursdays. I'm doing 40 cases, which means I have about 8 minutes per kid. That sounds terrible, but that's what I got. And so what would happen is in a normal week, on Tuesday I get the files from my probation officers. On Wednesday I'd spend a half day reading them all. Thursday I go on the bench and I'm doing them. And as you know, in a person's life, especially in a child in my system, a lot can happen between Tuesday at 4 o'clock and Thursday morning. And so is there a way in Watson to help me do a better, quicker job? And can I learn more quicker? And so people get afraid of artificial intelligence systems. I'm president of the National Juvenile and Family Court Judges Association. I'm going all over the country talking about technology. And frankly, if it's not IBM, it's Microsoft, it's somebody else that are going to create technological advances for us to use. And I have to look at all of those. I happen to have found this one to use. And I would say to you, be very honest today, I've not used the artificial intelligence aspect of it yet. Because it takes metadata, it takes information going in. So I'm using it now for a lot of other reasons. But by next year, it's going to give me some recommendations. And that's where judges get mad at me. Well, Judge, Tony, I'm a judge. I don't need a computer to tell me what the hell to do. And I say to them, you know what? Every day you're on the bench. You're a probation officer, defense attorney, prosecutor, a teacher, a probation officer. They're all giving you recommendations. So what's wrong with having another one that maybe will have less implicit bias in it itself? Really. And so this is what Watson has done. This is an example, and I want to take a mic. I know you can't see this, really, but I had created this on paper. And so the first 18 months of working with Watson, I was giving them information which they built into the system. And to be blunt, we went live with Watson June 1st of 2017. We're going live with my life court next month, April 1st, like next week. I'm going live with my family treatment court October 1st. And I learned my brain didn't work like a computer. And so a takeaway is that what I thought worked in writing doesn't work on a computer screen. And so as of June 1st, I've updated this 2 more times. So now it's like, 5.0. And now I think it's like 98% perfect. But I put down, and this is a dashboard. When I get on the bench, this is what I see. And there's all the information on the left about the child information. But in each one of those categories, there's a little plus. Because in each one of those categories, if I want to know the 50 last incidents versus the last 5, I can dig deeper in every area. And so I decided I felt I knew what I needed, having been a treatment court judge for 14 years. I teach all over the country. And this is what a judge needs to better chance to save a child. Better chance to save an adult who may be ODing. And so I focused on issues such as what's their progress in treatment? All their test results. Do I want to know, is there a pattern of test results in the last 5 or the last 50 or last 200? I can get all that looking at the screen. I have latest note. I have pro-social activities. I have school, education, home progress. And I had one special section put in there, the last touch point. Because at 9:30 in the morning when I'm on the bench and something happened at 7 o'clock in the morning, that same morning, my PO can go in that system from the back of the room and put in, Judge, you need to know this, what happened in the last 2 hours. And when I open up that screen for that child, it's flashing at me. Judge, you better read this, because this is hot off the presses. 2 weeks ago, I had a child who threatened to commit suicide. I didn't know that as of 8:30 in the morning. And they didn't appear in treatment court that morning. They were a no-show. So you should have warrant for their arrest. And my staff said they found him on the streets and brought him in for the afternoon docket. And as I did the afternoon docket, it was flashing. And the flash was, Judge, in the last 2 hours, he has threatened to commit suicide. You need to protect him and lock him up. Now, a PO could have told me that on the record, but that's in front of 40 or 50 people. That is so much more trauma for that child that by being able to read it on the screen, I could manage that situation and save that child's life right there. So, does it work? It works because instead of me spending 8 minutes in front of that kid using 6 minutes to read through the 400 pages of notes and files, I don't have to spend any time because I have that. And I can look at it in 30 seconds, refresh my memory from the morning, and make a difference in that kid's life. I'm not done yet. I could tell you a lot more, and I would love to do so. I would love to give you...
There's an off button here somewhere.
I know there is, but I would give you an opportunity to come to my court if you ever want to. Please feel free to give me a call, send me an email address, send me an email. I will help any way I can. Now, Bill, go ahead. Hey, you're no longer there anymore, so you can't yell at me as much.
Oh, okay, all right. Key learning. Which one of these things do you want everybody to remember?
You can create solutions. Don't take no for an answer. There are creative people in our country that can solve any problem if you give them an opportunity to do that.
Oh, by the way, we learned not to call it a workaround in front of legislators because they thought the administration was up to something when we were working around their rules. So we called it working within the system to find a solution. Yes, just to know that. Judges don't have to worry about stuff like that, do you? Most useful, best practice.
You can do these changes cost effectively if you think about how to do it. And you can think about all these solutions come up with so many benefits. You always think about one, but if you really spend the time to think about the cost-benefit aspect of it, you can convince legislators to make it work. Spend the money now to save lives later.
And I almost don't dare ask you, what is the biggest problem that you encountered that you solved? didn't work around, you solved?
The BEH people, behavioral health
That's behavioral
community.
health?
Yeah, behavioral health.
behavioral
So
health.
behavioral health organizations want to hide behind legislation, hide behind rules, and they were hard to work with. But through the use of MOUs and some other ways, we've got them to put in. So right now, we have BEH dropping information in my system. We're going to have education by the end of the year dropping information into the system so that it's all there for me to see without it being given to the PO who then has to upload it themselves.
Thank you. Tony, well done. Major Colonel, are you a state superintendent by now?
Nothing. Still
Juan
just
Colon.
Juan Colon. Good afternoon, everyone. All right. So,
Man, you got him to respond. It must
Oh,
be
yeah?
the law enforcement demeanor or something.
so I'm going to give you an overview, very brief overview of the drug monitoring initiative in New Jersey. I spent more than half of my career at the State Fusion Center, which is responsible for having alerts, warnings, and notifications about threat information, terrorism, natural man-made disasters, and also all crimes. But what surprised the heck out of me is that did not include drugs. We have Mike Senna here from the National Fusion Center Association, where now we're starting to see more of an influx of drug data coming into fusion centers. I mean, they were, after all, created to do analytics on all of the threats against a particular state. And finally, there's great capabilities are being leveraged to help protect people against drugs. So I've always been a big proponent of big data. So for me, working at a fusion center has been ideal. I look at corporations as the example. They leverage big data to protect their bottom line, which is financial, and government should do the same to protect its bottom line, which is the people that you protect. Just looking at government, how can this be done? Comprehensive data collection and analysis to enable the development of knowledge and understanding to improve public safety and public health. But that always becomes a challenge. As the judge said, there are some strategies there, data strategies that are misinterpreted, and excuse the graphics, for some reason it seems to be jumping off there. But most of, when you think of your IT departments, they're pretty much focused on defensive strategies, utilizing technical, physical, or even regulatory policies to protect data. However, my focus has always been on the offensive strategies to try to access the data and exploit it to really extract the knowledge out of the data that's available to all of us. So what drove me to start the drug monitoring initiative is that we started to see that the high number of shootings, high number of overdoses, and the high number of burglaries that were occurring throughout the state were being driven by heroin and opioids. So back in 2008 and 2009, we started the first collection with one of the state drug labs to start pushing information to the Fusion Center. And that was just the beginning of it. And then it was all codified and formalized in 2013 when we started to collect Naloxone deployment information from the Department of Health. So just to give you a perspective on the timeline of how long this has been going on. But one of the things that we realized was that when the State Attorney General's office said that we were to make this a formalized process, we went out and did a needs assessment from all of the partners throughout the state to find out what data is it that they needed to collect. We were challenged and found that a lot of the data was all over the place in disparate systems, and some entities did not want to share the information, and the all of this became very convoluted and complex. So based on the assessment that we did to find out what data needed to be collected, we identified some key resources and some key partners that had the data that we needed to collect. You could see them in the green circles. And the law enforcement data was all of the drug labs that then we formalized the collection process to receive information on the drug analysis results for heroin, pills, methamphetamine, all of the drugs, and also doing analysis on all this data in doing cross-data analysis for all the shootings, gun recoveries, all the different data that you see under law enforcement. 2014, law enforcement started to administer naloxone, and the state attorney general's office mandated that law enforcement officers send this information to the State Fusion Center. On the public health side, I was asked to join the State Epidemiological Outcomes Work Group because we started to share this information with them. They were quite surprised that law enforcement wanted to share information. And I heard a couple of comments since arriving here yesterday that law enforcement does not like to share data. Well, that's not the case in New Jersey and even in New York, even in Pennsylvania, where you're seeing a lot more data from law enforcement being pushed out to all of the partners in health and human services. So we reached out to those partners, and you could see the data sets that we're receiving from them, from EMS, all of the naloxone deployments, toxicology information from the medical examiners, PDMP data, drug addiction treatment data, and even now, the ones you see on the bottom, even neonatal abstinence syndrome data that's being pushed to the Fusion Center, and now also HIV, hepatitis B and C data, and you will see how all this comes together. But of course, there were some challenges at the beginning, interoperability, the trust issues. Think about it, a trooper coming over and asking for health data. There was a lot of hesitation by the health partners. There were a lot of, like I said before, the overly defensive data strategies, and then the sensitivities. HIPAA, Title 42, the criminal justice system, and 28 CFR Part 23, just some of those impediments to getting access to the data. But as the judge said, there are ways around those regulations where you can legally get access to this information, and you'll see what the results end up to be. Data management, data cleansing, normalizing. Before you do any analytics, any mapping, you need to do that data management. That was another key challenge. And then, of course, the analytical capabilities. You need analysts and you need software to be able to do those analysis. We don't have Watson, but right now the state is in the process of implementing the integrated drug awareness dashboard.
Juan, Stuart, Venzke, he'll be up in a few minutes for the rebuttal. He says he can get you a Watson for the right price.
Oh, yeah, okay.
Even though
if it's for free, it's for me. So as you could see, we're able to monitor the way the drug environment is evolving in New Jersey. You could see from those urban centers where the drug problem has proliferated to the suburban and rural areas of the state. And then tracking, and that's spatially, temporally, looking at the first quarter of 2015 compared to the second quarter of 2017, 2% of the heroin contained fentanyl compared to 30% of the heroin now containing fentanyl in the state. And that's as of 2017. Now it's upwards of 50% of the heroin in the state contains one of the fentanyl analogs. Speaking of analogs, the Fusion Center's tracking how many times people are dying, whether they were fatal, non-fatal overdoses, or involved in different seizures or arrests by law enforcement. And not just looking at fentanyl, but the specific one. You look at number 20, fentanyl, and this is one packet, this is one dose. Fentanyl, parafluoroisobutyrol fentanyl, fentanyl, and also a little bit of heroin sprinkled there. That was involved in a fatality. So that enables the Fusion Center to provide this information for emergency scheduling of these drugs. The good news is that there's more use of naloxone throughout the state to save lives, and you can see the upward number. The bad news is that fentanyl is involved in increasingly a number of deaths, and these are the percentages year over year, and then also tracking the number, the number of lives lost each year and the different fentanyl analogs that are being identified. So the number for 2017 is going to be somewhere around 2,600 lives lost. It's not because of a lack of effort, it's just that the potency of these drugs now that are being uncovered you can cut the number of users in half, and you're still going to have an increase in number of deaths because of the potency of carfentanil, acrofentanil, all of these different fentanyl analogs. It's almost that it's not that they're resistant to naloxone. It's just that people are dying that quick, and you can't get to them in time. So this capability of collecting naloxone is really quite helpful because you're able to conduct real-time biosurveillance. This is the form that law enforcement fills out anytime that they administer naloxone. What HIDA did was take our form and now created an actual application out of the basic form that you see there. They have the backdrop is the form that we have been using for a couple of years, and now you're able to extract all of this data that then gives you a better understanding of what's going on. So that's on the data side. Here's on the communication side. What we also established was this suspected overdose spike communication network involving the fusion center, poison control, medical examiners, local hospital, local PDs, and also the crime forensic labs to anytime any of these entities are seeing a suspected overdose spike, we would call each other and say, hey, what are you seeing? So like this, we're able to then confirm or dispel if in fact there is a spike of overdoses or not. So as I was saying before, these novel psychoactive substances that are being identified, if they're not scheduled, we use the supporting data from drug arrests, fatal and non-fatal overdoses to substantiate or justify scheduling these drugs. We don't just use it in the state, but then also provide it to DEA. Also, the identification of these cross-jurisdictional impact. In other words, looking at where drug arrests are occurring, but not just where those arrests are occurring, as you see on the left, but then also where do people reside and where they go to be arrested. So that journey to drugs becomes really important because then it helps us direct where the treatment centers should be focusing, and also their prevention centers, where they should be focusing some of their efforts and outreach. Our Human Services Department got a multi-million-dollar grant to provide naloxone and naloxone training. As opposed to taking a shotgun approach, we give them a sniper rifle where they're able to surgically go to the top 50 hotspots throughout the state where overdoses are occurring, but also looking at where these people live. So that journey to drugs becomes a very critical way of identifying where your most dangerous spots are and where the outreach should be conducted. Also investigating drug distributors. This is a network analysis that was being done for one particular stamp that was involved in several overdoses. And then also, like I said, the data is used for grants, budgets, needs assessments, just a variety of different entities throughout the state that call the Fusion Center for this data. And then the intelligence production. This is where the knowledge is documented and shared with your municipal alliances, your county coalitions, your governor's office, law enforcement, you name it, it's being shared in a variety of different ways. And then the foundational document for everything is the State Drug Harm Index, where certain drug harms data is being collected and being cataloged on a daily basis, looking at the actual numbers of shootings, naloxone deployments, deaths, and now it also includes the neonatal abstinence syndrome. So like this, you're able to rank to see which county is being most severely impacted, and then you can drill down further into the county and identify at-risk populations, and you can better deploy your resources statewide to those areas that are being most significantly impacted. And that's about it.
Okay, Juan, thank you. So a question for the audience. What would you tell the governor now after you've, thinking about this all day and hearing these presentations? And I might ask you all that question in a minute. But anyway, Juan, key learning.
Key learning.
I've learned one thing. He's retired, and he's available to come consult in your community for the right price, right? So we can take you to the governor. Go ahead. Key learning.
So key learning, to me, is how willing people are to share information, but the policies that we have in place are antiquated and they're really not helping our situation.
Most useful best practice.
Leverage your existing resources. There's a lot of, there are people that are doing things out there. There's all the data that you really need, it's out there already. Leverage it. You just need the right processes and the right platforms to get the information to one place to give you the knowledge that you need to create.
And big problem that you had to confront that you were able to find a solution for that might be applicable in other areas.
So the biggest problem, and I see here a lot of states that have great technology, and they don't have the data. Ours was the opposite. We solved the data collection problem, but then we're consumed by how much data. So the data management piece is by far the biggest challenge. Because if you want good analysis, good results, you're going to need not just good data, but good, cleansed, usable data to really get good results.
Very good. Now, I'm going to ask audience, does everybody know what a fusion center is? Anybody would like him to explain what a fusion center is? I was worried that there may be an audience here that didn't understand your part of the world. Could you tell them what a fusion center is?
Sure. So a fusion center is a place that Mike Sena can explain, because he is the president of the National Fusion Center Association.
Okay,
Come on, Mike, take it away.
Mike, stand up and tell them what a fusion center is quickly, because we've got time for questions, and I got to get Stuart up here.
So 79 fusion centers across the country developed for cross-disciplinary capabilities of bringing in data information analysis. There's a fusion center in every state in the country, 3 U.S. territories. I will leave cards with Daniel because I have to take off early. But if anyone wants more details, unfortunately, more details, give me a call. We'll get you more information about fusion centers, how to connect with fusion center near you.
Questions for the panel? Yes, sir.
Good afternoon, Dan Chavez. Thanks for all the great work that you're doing. I'm San Diego Health Connect, the HIE in San Diego and Imperial counties. It's interesting, none of you mentioned prescription fill data. I am curious as to your thoughts as to why you're not utilizing prescription fill data, your access and the availability of the data. I can speak from the HIE perspective, this is a huge gap in the medical records that we're collecting and sharing as a public health information exchange.
So what specifically do you mean when you say prescription fill data? Are you talking pharmacy data specifically? Yeah. So we do actually use that. That data comes into the prescription drug monitoring program. That's how we know exactly how many milliequivalents of morphine milliequivalents have been distributed at any given time. So that data does come into our dashboard, for example. You can literally see number of prescriptions and what the average milliequivalents are.
That's prescribed,
Yeah.
filled. What was actually,
Well, that is what we get is filled. We don't get prescribed. We get what the so it's the pharmacy that's entering that data. So that's what is actually coming into the system.
In Virginia, we get the prescribed or the filled as well. Juan or Tony?
I simply say, as a juvenile court judge, I don't care. I'm just seeing the kids die. So I don't, and kids don't normally have the prescriptions filled, so that's the other. It's in Ohio, all those rules are there, but I'm dealing with the reality every day. I don't care if they're buying it by prescription. My bigger problem is them stealing their parents' and grandparents' drugs. So I tell grandparents, if your grandkids come to see you too much, because they're going into your bathroom and stealing your meds. Because the reality is, if your kids ever tell you they're going to a salad party, a salad party is where they go when the access to the party is bringing 5 pills from a medicine cabinet. You don't care if it's up or down or whatever. You throw it in the jar, and when kids show up, they take 2 pills and 1 can of beer. They don't get a DUI because it's 1 can of beer. They take 2 pills. They don't know what it is. So from my perspective, that's what I'm looking at.
Juan?
In Jersey, they call that the Skittles party.
Yeah, okay.
Because it's all different pills. But yes, we do receive the fill data from PDMP, and we utilize that data to establish a baseline to look at, abnormalities. So that is the information that's used to look at which doctors may be over-prescribing and which patients are traveling how many miles. There's a baseline, and then looking at those outliers that may be 75, 80, miles to travel to one doctor. So all of this information comes in when the pharmacy fills that prescription.
I would add one thing in Virginia that we are worried about is that the inability to get the data from the pill mills, the methadone clinics, buprenorphine clinics that's protected by CFR 42 is a problem. There's a hole in the system, so you can't just assume everything's okay because you don't see doctor shopping outside of those. Questions? Yes, Uma.
Hi, I'm Maluan in Montgomery County, Maryland, the other Montgomery. My question is, we're talking a lot about data being available. What kind of work are you doing behind the scenes? to
Hit the button,
educate-
Uma. It's got to turn green.
What kind of training and other practices are you using behind the scenes for people to actually use the data, to ask the right questions and to use the data responsibly? We spent so much time initially trying to get the MOUs in place to get the data. We didn't pay enough attention on the back end as to what do we want people to do with the data, and so that was sort of, now we're smarter at it, but that was an important oversight initially in our journey.
So one of the ways that we've, that's actually, one of the biggest challenges that we have is having enough people to actually manage the data, to clean the data, as you said, make the data actually usable and turn it into information, which is the biggest. We did a lot of work on the front end before we put the opioid dashboard out to the public to make sure that not everything that we get is in there. And that's because while that data is useful to us as parts of our surveillance program, it's not really interpretable by people who haven't had specific training. So for us, because we intended that tool to be used by anybody from like a high school student who wants to study, is doing a paper, to any number of other local coalitions, et cetera, to put the data up there in a way that was easy to manipulate, but also comes, if you hover over any specific piece of that, you'll get information about what the limitations on the data are, how old the data are, what it doesn't mean. We do suppress some data that's really low numbers that could potentially create misinformation. So that is a huge challenge. You can buy all the analytic software you want. If you don't have the money to pay for the people who know how to use it and to use it appropriately, you're going to end up with a lot of useless data and no information, basically.
And mine was reversed because I wasn't trying to find out drug problems for children anywhere else besides the kids in front of me. So I was focusing on 100 or 500 or 1,000 kids. I didn't care if there were 3 million kids. I mean, I care, of course, but my focus was on a smaller group of people. And my use of analytical data was to help me, give me a solution. And this is what I envision. I have a child who's from this neighborhood who has one parent versus two, who is this socioeconomic background, fourth grade education, biracial, lives in this neighborhood, and I have 8 treatment centers to send that child to. What's the best possible location that could help succeed, that could help this kid succeed? That's what I was trying to find out. I wasn't trying to find out where the 27,000 kids were. So it's just the opposite of what they're all doing. But training is the biggest challenge we had too. We have this great system now, but training staff to be able to focus on what the needs are and really understand what we were looking for was a challenge.
So our data collection requirements are based on customers' needs. So whenever we're doing any analyses, it's based on what they told us they want us to collect and also do analysis on. They know why they requested this data, and they know how to use it. We're not educating our folks on how to use the data. But on the law enforcement piece, when we're telling that, when we're providing information about a particular fentanyl derivative, we will then say or provide a caveat about the potential potency of this particular drug. But how they use the data, I mean, we're not doctors in law enforcement. We're just giving them an understanding of what's out there, and then they can go out and use the data as they need.
Okay, I'm going to ask, if I may, the last question before we bring Stuart up. You have 3 minutes, and if the genie came along and gave you 3 wishes, for what we should do related to data and this epidemic, what would your 3 wishes be? Karen?
Well, I'm a bureaucrat, so it would be
You're going to get about 10 in here, I can tell.
sustainable funding for the human infrastructure to use the data.
Boy, that's only one, but that's a big one. My concern, I'm going to tag onto that, is if we're fortunate, if you look at this epidemic, we're going into this crisis where we see ever-increasing numbers. If we're lucky, what will happen? They won't die, and we will have to manage people with a chronic relapsing disease for the rest of their lives. And how do we build a system that channels them back in when they lapse to the right treatment? I'm sorry, that's my extent of your wish. Tony?
That was my wish. I have kids. I treat them. I send them away. Send them back to the same community, same family, same scenario. They're going to die. Second wish is getting doctors to understand what their role is. I've had a lot of doctors, ER doctors in the last year and a half tell me, Tony, why do I do this? Why am I saving people's lives? Because they're the same people every other weekend coming back. And I can use my skills to save other people. So I think the police departments and the doctors of the United States are having a philosophical crisis. They're supposed to save lives, but they're getting to believe that these people aren't worth saving because they're saving them too much. And the third issue is a stream of financial assets available to maintain the project.
Mm-hmm. We see your second problem in Virginia, where the repeat naloxone is an issue, because now the naloxone that was funded by the grants is expiring or running out, and they need more, and who pays for it? And the question is it worth it? So we have to get past the anecdotes to the anecdata, which is more than a couple of cases. Juan?
So my first wish would be that anyone that has been successfully reversed with naloxone, that there would be a HIPAA exception, that their information could be used to look up their name through PDMP, because it's a great indicator of abuse. Not someone that has been received naloxone, because anyone could be administered naloxone, but that has been successfully reversed through naloxone. Second one would be that the CDC would give the funding to those remaining states that are not utilizing, let's say, image trends. So like this, all of the EMS providers that are reporting into image trend, you can actually go in an hour and find out how many times naloxone has been administered throughout the entire country. Because already, I think it's 41 or 42 countries are utilizing image trend. And the last one is that, I guess for the labs, the crime labs, that they would have all of the standards and enough reference material to test all of the fentanyl analogs that are out there.
Just one thing, one of the most remarkable things about Juan's program is the turnaround time. That data comes out how quickly? I mean, in Virginia, it's taken us 7 or 8 weeks to get the compounds, but you could turn it around how quickly?
If there's a spike in overdoses and testable specimen is found at the scene, it's been turned around in about 2.5 hours.
Real
so they're able to
actionable
identify which
intelligence.
Substance is it that's out there killing people.
Yeah. Stuart Venzke from IBM sponsoring us. IBM, Stuart, your turn.
So this is, first of all, a wonderful conversation and wonderful presentation, so thank you all. I guess the more of a thought I have, and maybe a question, is it's completely reasonable and appropriate to be focusing on opiates and substance abuse death more broadly, but they are sometimes viewed as a subset of a broader array of deaths of despair. And I wonder, to the extent to which you think the same interventions, models, data and interoperability tools would actually apply to things like suicide and alcoholism and so forth.
So we're actually trying to do that right now. We have we're part of the National Violent Death Surveillance System. It's a pilot project. It would be amazing if we could get much broader information than we have on what are the social circumstances in which people who commit suicide, for example, versus those who, homicides, et cetera, domestic violence, but particularly suicide, because it's so very specifically, about that person's individual circumstances. But if you could bring together all the kinds of data that you have at the local level, but tax data, et cetera, you can learn a lot about somebody. You can learn about what their educational background is. You can learn about what their family setting is, their degree of social isolation. We know from large population studies that certain factors predispose, but we don't have nearly enough information to be able to do anything that looks like prediction or understand when a community is beginning to have problems as a community. And if you know those things, you can start to intervene upstream from the actual problem.
I think we can use the same kind of analytical data to help on issues of veterans courts, alcohol courts, domestic violence courts, any kind of a legal problem where there is a health issue as an underlying cause. And I do think you can predict with enough data some possible solutions. And so I see this working in all those kinds of courts. And because we have so many people in our country who have medical challenges, I see this as a way to hopefully solve a lot of those issues.
So I look at the opioid or drug issues. It's something that law enforcement and many health entities encountered these individuals. And each one of those encounters is a drug data touch point. And all that was done in New Jersey was to identify all of those drug data touch points and pull the data to paint the picture of what's going on. It's a very simple concept that can be applied to just about any problem that you're trying to identify. So if it is veterans, well, where does all the veteran data go? And then collect the data from all of those touch points.
Clearly, substance abuse of any type, behavioral health issues, people bounce in and out of the system and in jurisdictions. That's the other piece. Something gets in one jurisdiction and maybe Tony doesn't know about it because it's not there. So I think the opportunity for us, this Congress put $4.65 billion into opioid-related research and treatment programs. How will we know if it's working? I mean, that's a big piece of it. Karen just reminded me about that. We have opportunities, but if we build it only around opioids, we miss the future, I think.
It can also help in another a backdoor way, in that it helps you understand what treatment providers are doing a good job. Because when you use your data and you're finding of the 20 providers that all my kids are failing out of 3 providers, and a bigger picture, I may not see that, but the data doesn't lie. And so it can help do that.
Okay, we got it. The answer is these local folks are really doing a good job with the technology. They really are. But thank the panel, and thank you.